Now, you know, patients with STEMI have acute coronary occlusion and they need acute intervention to relieve the ischemia. Non-STEMI patients are traditionally looked upon having non-occluded arteries, but they have plaque rupture, thrombus formation, and imminent vessel closure. Some also have ongoing ischemia, and even some have ECG silent occlusions. So the standard strategy today to investigate them within few days may be too late. So what the verdict trial aimed at was to address a standard invasive strategy versus a very early invasive strategy within 10 hours. That means early angiography and subsequent revascularization if needed. We included 2,000 patients, 1,000 in each arm, and they were randomized in a one-to-one fashion to either standard therapy or an early invasive strategy. So a very simple randomized study. Yeah, we presented the main data from the study and the overall endpoint, which was a composite endpoint of death, myocardial infarction, rehospitalization for heart failure, or recurrent myocardial ischemia, was neutral in regard to all of the patients. But when we looked in pre-specified subgroups, there was a significantly lower event rate concerning recurrent MI in favor of the early invasive arm. And there was a trend towards the same picture regarding his hospitalization for heart failure. And we also did subgroup analysis, which was also pre-specified, and patients with a high gray score. High gray score means that patients are a priori at a high risk: age, poor renal function, high blood pressure, elevated heart rate, etc. If you take those out, those with gray score above 140, they have a significantly better outcome with regard of the primary endpoint if they receive the early strategy. So interestingly, 30% of the patients had no significant coronary artery disease. And this tells me that the modern high-sensitive troponin assays are extremely sensitive. So they take in all the patients on the basis of troponin, and you catch the patients with coronary artery disease, but you catch a number of other patients that have no disease or have different diseases, atrial fibrillation or high age. So I think that the primary endpoint was to some extent diluted by these patients that did not have coronary artery disease. And we will, of course, redo the analysis if we take out the, so to speak, normal patients and see what that leads us to. But that's exploratory, and the database was closed a mere 4 weeks ago, so there's a lot to do from now.